Hi, I'm Helen Bauer, and this is the Heart of Hospice Podcast. The Heart of Hospice Podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode is being sponsored by bkbooks.com. BK Books helps care teams and families understand what to expect at the end of life. Created by Barbara Carnes, these trusted booklets and videos explain the physical and emotional changes of dying with warmth and clarity. Whether you're guiding others or caring for someone you love, BK Books brings understanding that eases fear and fosters peace. Explore our compassionate resources at bkbooks.com.
I'm thrilled to welcome Pediatric Palliative Care physician Dr. Jared Rubenstein to the show today. Jared Rubenstein is a pediatric palliative care doctor and medical director at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. As a fellowship program director, he works to train the next generation of healthcare workers in providing person-centered care. Jared is passionate about helping people talk about difficult things and believes that the use of satire, animation, and humor can facilitate those hard conversations. His YouTube channel contains original animated videos utilizing these principles, and they address topics like serious illness, mental health, gender equity, and racism in medicine. The videos have been viewed over 150,000 times, and they're used nationally and internationally as teaching tools. You can find Jared's work at jaredrubensteinmd.com, and that's RUBENSTEIN. He's also on Instagram, Threads, Blue Sky, and YouTube as at Dr. J. Rubenstein. You'll have links in the show notes to find all of those connections to Dr. Rubenstein and the work that he's doing. One of the things Dr. Rubenstein focuses on in his pediatric palliative care practice is the personhood of each patient. And he's going to talk a lot about that. He talks about how he integrates the use of dignity therapy in the care of PD patients and how they modify the dignity therapy according to the child's age and abilities and understanding. Jared also shares how he's inspired daily, not by just his patients, but their families and parents too. Dr. Rubenstein's passion for the work he does with his palliative care team is very evident in our conversation, so keep listening to the end. There's a lot to learn. Dr. Rubenstein, welcome to the Heart of Hospice Podcast. I'm so glad to have you with me.
Yeah, thank you so much for having me. I'm really excited about this conversation.
I know we've already been talking a little bit. I've been getting to know you some, so I'm eager to let my listeners get to know you. But we're going to start with an icebreaker question that I did not send you. I'd like to sneak that in. And it gets down and dirty really fast. So here's your icebreaker. Tell me an end of life wish that you have that's part of your advanced care plan.
Ooh. I like eating a lot. And I know not everyone has an appetite at the end of life, but I've always had a vision of having like a pizza party. And that to whatever degree I'm able and the people that are there, that we're eating pizza together. And then I'm surrounded by the people I love, and then I can just gently go.
I totally love that. I'm not sure how realistic it is to think that you're going to eat pizza and then just drift off.
Oh, I know it's not at all realistic, but it's
No.
a nice vision.
That's a TV movie version
Mm-hmm.
of a death, I think. But I like the sound of that. I have to say that I've always said, I try to restrict my sugar and things like that. But I've said that if I was ever diagnosed with a terminal illness, I'm going to eat whatever the hell I want.
Absolutely.
Yeah. I don't know that I would do that, but it sounds good, doesn't it?
Yeah.
Yeah.
Eating's great.
Let's face it. We use it to comfort. I was doing a self-care talk the other day, and I was talking about fueling your body instead of just feeding it. And I said, if you cover it with gravy, it's probably not fueling. It's probably just comfort eating. So, okay. Well, we're talking about some serious stuff today. So it's good we had a little laugh to get going. You work in a pretty serious area. You are a pediatric palliative care physician. Tell me about the work that you do.
Yeah, so me and my team, we're a big group here. We have doctors, nurses, social workers, a chaplain, a psychologist, and we work at a big children's hospital. And we have both inpatient and outpatient teams. I focus on inpatient because I trained as a hospitalist initially, and so I'm really comfortable and really like the inpatient setting. And we take care of anyone with a serious illness and their family at the hospital. So some of our patients have cancer, some of our patients have congenital heart disease or acquired heart disease, lung disease. A lot of our patients have genetic diseases or severe neurologic impairments, either from prematurity or some other reasons. And we meet families wherever they're at. We take care of them ideally from the point of diagnosis for certain illnesses and follow them along through the end of their lives. And then we're lucky that our team's also able to provide bereavement support. And so we follow the families after the child's death as well.
So what age groups are you working with?
So anywhere from birth up to young adulthood. In pediatrics, we're never probably as good as we should be about letting our patients graduate into adult healthcare. And I think in fairness to you, the adult healthcare world isn't always as welcoming of some of our patients as they could be. And so we have patients into their early 20s, 30s in some cases.
Really? I mean, that makes sense for continuity.
Yeah.
Yeah.
And I think there's some conditions that people didn't used to live until adulthood. And so folks in adult medicine didn't necessarily get training in it. And now, as children are living longer with these conditions, they become adults. And still, it's the pediatric folks that I think have kind of the knowledge and expertise and willingness to continue to help them with their illnesses.
It's interesting. So tell me a diagnosis that would be an example of that.
So congenital heart disease is a big one. There's now great partnerships with both pediatric cardiologists and adult cardiologists to kind of help bridge the gap. And severe congenital heart disease, where people didn't used to survive until adulthood, now people do a lot, which is great. I think another one is certain rare genetic diseases like trisomy 13 and 18. It's certainly very rare to survive until early adulthood with it, but it happens. Also, children with prematurity that have severe neurologic impairment and usually are not able to talk or walk or care for themselves. And they have what ends up being a very intertwined life with a parent or caregiver, and will routinely live into teens and in some cases early adulthood. And their home has always been the children's hospital, and it's where they get their care and it's where their family feels supported. And so our teams are comfortable and happy to take care of these kids for as long as they need us to.
I can imagine that there's a great deal of stress for a family caregiver that's involved with transitioning from a pediatric team to a whole new team for adult aged care.
Absolutely. And I think from the families and also for the patients themselves, I think we sometimes for diseases that run in family, will have patients that will have an older sibling that has transitioned and it doesn't go as well as could be hoped. And then the younger person who's our patient becomes scared of that transition and sort of dreads it in a way that I wish wasn't the case. But I think we have a ways to go in sort of getting to bridge the pediatric to adult gaps.
I've never thought about that as a silo inside healthcare. We talk a lot about how siloed we are. We're very separated. And of course, hospice is on the tail end of that, but we are definitely separated and segregated away from the other sections. But from pediatric to adult care, I'm assuming would it be the same sort of thing?
Yeah, I think it absolutely is. And I think there's been growing collaboration and now there's people, opening up transition clinics that's sort of their whole focus and expertise is helping people with chronic illnesses transition from pediatric to adult care. But it's a challenge for sure.
Yeah, I can imagine that's a big need. So one of the things you have on your website is that you believe that personhood should be maintained throughout a child's experience in the healthcare system. And I mean, good Lord, the healthcare system is so fragmented and so broken. And that's for adults who are educated and trying to get through it. But for a kid, there must be special challenges. What does personhood mean when you're talking about a child?
So really for me, I think it's not a ton different than an adult. And I think it's really just giving kids credit that they're whole people too, and that they probably have a lot of the same needs and wants and desires of an adult. And it's often that I think we don't do a good job of empowering that. Like I think there's always a debate about, how much to bring a child into discussions about their illness, especially if they're a younger child. And what certainly there are some kids that say, I don't want to, but more often than not, we see that kids very much want to be part of those conversations and often aren't given permission either by their parents or their doctors or some combination of the two. And it's coming from a good place of wanting to protect them. But ultimately, I think it makes it harder for them and harder for everyone because you have all these people that care for each other, not able to talk about the most important thing happening to them with the people that they want to be able to talk to about it.
Yeah, it's the elephant in the room.
Absolutely.
Yeah. That's not much different from the way it is for adult patients.
Yeah, I think so. Yeah. And I think particularly for kids, and a big part of our pediatric palliative care population has an atypical neurologic baseline, and that they don't look or act or live or walk or talk in the same way that a typically developing child does. And I think for us, it's hard until you've walked that walk and lived that life. I don't think any of us in the field really know what it's like unless we've done it ourselves to care for either a technology dependent or a medically complex child at home. And something I've started doing and have been doing for the last several years is when I meet a child and family for the first time, it's hard to get a sense of who they are as a person because I'm always seeing them not at their best because I work in the hospital and they're sick and they're coming in a weakened, disempowered state. And so I'll ask the parent, because everyone has a little video recorder in their pocket all the time now. I'll say, can you take out your phone and show me some pictures and videos of what life's like at home and what your kid is like at home? And I think it's such a good way to see what they're actually like and what they look like and what their baseline is in a way that I think there's no really other way to describe or imagine. And I remember once I asked a patient's mother and she said, I've been coming to this hospital for 10 years, and started crying and said, in 10 years, this is the first time anyone's ever asked to see what he's like at home. And that was just so heartbreaking. But also you can see how it happens because it's not something that's part of the routine admission and part of somebody's day and part of the way that we talk about healthcare, but it should be.
Yeah, it should be. But that is personhood, because your personhood has to extend beyond just this crisis moment that you're having in the hospital.
Absolutely.
Right? Our patients do a lot of life and a lot of living before we even come in connection with them. So when it comes to pediatric patients, how do you support that personhood? Obviously, you're getting to know who they are when they are not in a crisis or as well as they can be. But how else do you support their personhood?
So really just talking to them, and if the child is awake and old enough and able to speak, asking them, what do you do for fun? Are you in school? What do you do outside of the hospital? what makes you happy? What does a good day look like? What does a bad day look like? Just things about sort of not even related to their medical care at all. And we'll get there. But what I'll usually say is, and I borrow this from Harvey Chachanoff, the person who created dignity therapy, and a colleague and I went and did the dignity therapy training some years ago, and they have the question, what do I need to know about you as a person to take the best care of you? And I really like that question, and I'll open a lot of my consults with it. And I think adults get it, older kids get it. I think younger kids don't always know what to do with that question. And so it's more just, what do you do for fun? What do you like? What are some of your favorite things? What would you be doing if you weren't here in the hospital right now? And I think it's a way, and I'll usually say, whether it's to the child or to the parent, I've read your chart, so I know the medical stuff. Like, I don't want to talk about that now. I want to know what else there is about you. And I think what we see sometimes, and it's heartbreaking, is that they're so used to talking about the medical stuff that it sometimes catches people off guard, and they don't know how to talk about the other stuff at first, because it feels like, am I supposed to talk? Like, this is a hospital visit. Like, why are you asking me about this stuff? But what I hope that they get to know, and actually, when I meet a child and their family for the first time, I actually like to tell them, I ask them if they've heard of palliative care. I ask them if they've heard about what our team does, or if their other medical teams have told them anything about us. And then I tell them a little bit about who we are and what we do before I start asking questions. And I do that for a couple of reasons. Is one, I hope that it gives them a sense of who we are and build some rapport and comfort before I start asking them these very personal questions that I think can feel invasive if you're not used to talking about it in a way that feels sort of perverse, because like putting needles in people and asking them like very personal medical questions is now routine. But saying like, what makes life worth living, or what do you do on a good day for fun, feels personal and invasive in a way that these other questions don't. But I also want people to know who we are and what we do, and kind of the lens we're going to be looking to help them through, as a way to sort of think about the answers we kind of might want to our questions.
Do you find a lot of people in the pediatric sector of healthcare, families, parents, don't understand what palliative care is?
Most don't. I mean, anecdotally, in my experience, most come in kind of as a blank slate. And some people have heard of it, and some people have positive or negative connotations from, like, every now and then we do meet the person who says like, oh, palliative care, that's like hospice. My grandma was on hospice and they came and shot her up with morphine and then she died.
Right.
And so that bias is out there, but much more often people come as very blank slates. And what we've seen in our experience, and what the data shows when it's been studied, is that when the general public has negative conceptions about palliative care, there's some of it that are those stories that I shared, but more often than not, it's the way it's described by other healthcare workers and the way it's described by other medical teams, with sort of tied to failures or tied to hopelessness, or tied to things like, I'm sorry, there's nothing more we can do, so here's the palliative care team. And we get kind of tanked before we meet them. And so I've kind of evolved over my career too, of asking, when I was getting a consult, saying, make sure you tell them we're coming, and make sure you talk about us, to saying like, you know what, if you don't, that's fine. I'd rather me do it. And if I come and they have no idea who I am, that's great, because then we can start from the beginning and I can tell them who we are and what we do as I'm getting to know them. And I say to them, as we get to know each other, I hope you'll use us as a sounding board or kind of a planning partner for thinking about your medical care going forward. And the way that we do that is for you to understand what we're about and for us to understand what you're about.
I have to touch back, because this is such a pain point for me. This whole thing where somebody says, there's nothing else we can do for you. We have got to stop saying that. I don't care what your discipline is, what your silo is. We've got to stop saying that.
Absolutely.
So what I see when you describe that situation to me is, you have a patient and a family, and the healthcare provider says, we're at the edge of the cliff. I'm not going to help you, but I'm going to shove you off, and I'm going to send you to palliative care or hospice. So the patient's down in the bottom of the canyon, and the hospice or palliative care people have to help them climb up and reestablish trust that was already damaged before you got a foot in the door, before
Absolutely.
you even meet people. We've got to stop saying that. I think saying there's nothing else we can do, first of all, that's not true. And second of all, I think it damages people's trust in us so badly.
100% agree. Yeah. And I think so much of it is framing. And this is what I think and talk about all the time now, is, asking people, People say, how should we ask a family if they want a palliative care consult? And I say, well, you shouldn't. Like, you don't ask them if they want a cardiology consult or an infectious disease consult. You say, hey, this is happening. I'm going to bring in the palliative care team. And that's part one. And then part two is, you, just like you do for any other consult, you tell them why. You're really struggling with pain. We're going to bring in the palliative care consult. They have the expertise in pain management. And then part three is, you turn around and you walk out the door before you project your own insecurities and biases and misgivings that you have about it and wreck everything before we even get there. And I think, so that's what I always recommend to people, is kind of the 3-part plan for bringing in a palliative care team, but also even the way you talk about it, the way we talk about other things like, I'm sorry, it looks like you've been diagnosed with appendicitis. Good news, we have a world-class surgeon at this hospital that is fantastic at treating appendicitis. Or, I'm so sorry, you have this rare type of cancer. Good news, we have the best expert in that cancer at this hospital. But instead it's, I'm really sorry. We can't treat this. Your cancer's not getting better. Here's palliative care. Instead of, you're dealing with these really challenging symptoms as you're going through your cancer treatment. Good news, we have an amazing team of people at this hospital that helps people through cancer treatment and whatever comes next, called the palliative care team. We're going to bring them on. I'm so glad you get to meet them.
Yeah, there's support for this.
Mm-hmm.
Yeah, it's all in how you say it. Absolutely it is. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
When someone you care about is nearing the end of life, it can be hard to know what to expect. BK Books is here to help families, caregivers, and professionals find comfort through understanding. Created by hospice nurse and end-of-life educator Barbara Carnes, these simple, trusted booklets and videos explain what happens when a person is dying, the changes that occur, the signs you can expect, and ways to bring comfort and provide care. With clear, compassionate information, BK Books helps you face one of life's hardest moments with confidence instead of fear. Whether you're supporting a loved one or guiding a family, these resources make a real difference. Resources from BK Books have helped hundreds of thousands of families and healthcare professionals navigate dying with confidence and compassion. People don't die like they do in the movies. Understanding what's happening can bring calm when everything feels uncertain. Explore the trusted guides and learning tools from hospice pioneer Barbara Carnes at bkbooks.com.
So I want to hear more about the dignity therapy, because I had Dr. Harvey Tachanoff on the show to talk about it. And it's really amazing. It's being used quite a bit all over. And I have a lot of hospice and end-of-life workers that listen to the show. So how do you incorporate that, especially with your younger patients? How do you do that?
Yeah, and so a few different ways. When we went and did the training, it's probably 6 or 7 years ago now, that was our big desire, was to come back and see if we could modify it to pediatrics. And Dr. Tachanoff has been wonderful and supportive as we've kind of worked through and tried to figure it out. And we really think about it in a few different ways. For adolescents, we do it almost exactly like the original protocol, where you do the recorded life review interview, recorded advice. That's the other thing. I think people would be surprised that, adolescents would have advice they want to give, but of course they do. Who thinks they know more about the world than an adolescent? And
that's a good point.
they want to say things to their family. They want to say things to the people they're leaving behind. A lot of the adolescents we've worked with have asked us to keep a copy of their dignity therapy at the hospital to be able to share with other people who have their same disease, so they could read about them and sort of see another person that's going through that. So for some of it, we don't do it that differently at all. The big challenge I kind of alluded to earlier when I was talking about that, we don't let children talk about these things. There's so many hurdles to be able to empower a child just to talk about what's happening with their body, that's often the biggest challenge we see. But if we get someone who is aware of what's happening to them, wants to talk about it, is interested in legacy work, and is being given permission to do it, we'll introduce the idea and talk to them about it. And so for adolescents and older kids, we do it very similar to the adult model, but we found that oftentimes teens want to have pictures of themselves in it. I know the original document is largely text-based, and so a lot of the ones we've done for adolescents have had pictures of themselves. And we had a couple of fantastic patients that were artists and wanted to have some of their art included as the cover and part of it. And so they they gave us a photo of their artwork to put in it. A population that we really were excited to work with, and shout out to my partner, Taryn Schulke, who was the grief specialist on our team at the time we were doing this. And she was the one that was really a big driver of the two of us being able to do this work at all, but particularly to kind of think about modifying it to different populations. And she had the idea for pre-verbal or nonverbal children, whether it's that they're just like it's an infant in the NICU and they're pre-verbal because they're not old enough yet, or a teenager who has severe neurologic impairment from some sort of brain injury or abnormality that's never been able to talk. And knowing that they have this shared life story with the parent or caregiver, we implemented a dignity therapy by proxy protocol and interviewed the parent or caregiver about the shared life story. It's a way to enhance the dignity of both parties and talk about their shared life together and really honor both of them. And so the parent or caregiver can talk about the experience of being the main caregiver for this person for 5, 10, or 20 years, and really talk about their life together as a way to both honor the child and honor who they are as a parent or caregiver that has put in the work and loved the child and cared for them all these years. And some of those have been really powerful to do. We also had a vision that we haven't really been able to complete yet, I think because of some of the challenges earlier. I mentioned that for kind of the middle-aged kids, of doing adult facilitated one and having sort of the parent there with them to help them tell their own story and kind of prompt. But we haven't been able to do one like that yet, in large part, I think, because those are the kids that it's the hardest to be able to engage in these conversations because of all the barriers.
Right. Do you ever get pushback from parents who may not be as comfortable with doing, basically it's a legacy project, which there has to be some acknowledgement of disease progression and prognosis, et cetera, which there's a lot of grief, right? It's anticipatory grief.
Yeah.
Do you get parents that refuse and push back and say they don't want their kid doing it, or they're not capable of participating?
Oh, for sure. And it's not so much pushback to dignity therapy, because I think we have a pretty good radar that we won't introduce it if we think it's going to have that barrier, that we want to already be having these conversations. But there's very much pushback just to those conversations at all. And again, it's coming from a good place. I think the term that's been coined for it is mutual pretense, where there's, the child and the family in the room together, and that both of them know what's happening. The child is in their body. They can feel it deteriorating, and they know they're spending more time in the hospital. They know they can't do the things they used to. And they know that whatever's happening is really bad, and their parent seems to not want to talk about it. And so parents, coming clearly from a place of love and protection, are saying, I don't want my child to see me cry. I don't want my child to know how hard this is going to be. I definitely don't want my child to know that they're dying. And then you have a child that I think most of us suspect probably does know that they're dying, and also knows that people don't seem to want to talk with them about it. And because they want to protect their parents as much as their parents want to protect them, they don't want to ask, because they know it's an uncomfortable conversation that people don't seem to want to talk to them about. And a lot of time our work is trying to bridge that divide and really just get these people who love each other to talk to each other.
Yeah. I mean, that's a big thing. Mutual pretense is the term you used.
I believe so. Yeah. I think that's the term that's been coined for it.
You pretend I'm okay and I pretend I'm okay, and we just rock along. Well, and I would say that we experience a lot of that between parents and children when the parent is ill and geriatric. We still get that in
absolutely.
hospice. Yeah. It's the elephant in the room. If we don't acknowledge it's there, we don't have to deal with all those issues that come with that. So hard.
Yeah. Yeah. I mean, I know a lot of people are scared of pediatric palliative care and pediatric hospice that work in palliative care and hospice, but I really think there's certainly nuances. It's not the same. There's this mantra in pediatrics that kids aren't just little adults. And I think that's true, but you'll never convince me that adults aren't just broken kids who have been weathered by the world and have seen too much. And I think the conversations end up being kind of the same, just in different directions. And everyone loves each other, and everyone's trying to protect each other, and everyone doesn't want to talk about these hard things. And so certainly there's this element of just heartbreak and unfairness that it feels like it shouldn't be the way the world is if a child dies before their parent.
Right.
And the conversations are also similar, that whether you're talking to the parent of a child or the adult child, a dying parent or a spouse, they're all kind of similar conversations.
Yeah, I mean, isn't an adult just a child with more baggage because they've lived
Absolutely.
longer? Yeah, I like that. I think that's beautiful. If we could actually talk to older adults in those simple terms, especially the use of the dignity therapy, because those questions are so real, um, and get past a lot of the extraneous stuff. If we could just simplify it down, wouldn't that be so much better an
Absolutely. I
approach?
think I'm obviously biased as a pediatrician, but I think there's a lot the adult healthcare world could take from pediatrics.
Yeah, I think there's a lot we could learn from kids in general, how they approach
Absolutely.
life. Yeah. So you obviously have worked with some amazing kids and amazing families. Tell me about a time that you were inspired by one of your patients.
I mean, there's so many of the kids that I've taken care of that are just incredible that it's hard to kind of pick just one. I think for me, as someone who's now a parent of two young kids, I'm daily inspired by the parents and just feeling like being a parent's hard, and being a parent in the hospital is harder, and being a parent in the hospital of a child with a serious illness is the most impossible thing in the world. And just being there under a microscope and being there and being vulnerable and still showing up every day and advocating and asking questions and taking care of your kid and making sure that they get the best is completely inspiring to see. And it never gets old. It never stops being, I think, the most remarkable. And we talk to parents a lot, and I always try to never leave a visit without telling the parent that they're doing a good job and they're a good parent, because as a parent, I know that I always feel like I'm not. And I for sure know that when your child has an illness, it feels like it feels like you're not doing the best because they're sick. And whether it's talking about that or whether it's talking about like asking people where they find the strength to do this, which is another question I like a lot to get to know them. Oftentimes they say, what choice do I have? And I think they do. And I think the people that say that feel like there's not a choice because it's inherent in them that they're a good parent and they're doing it and they're showing
Yeah.
up. But of course they have the option not to, but they're not taking that. And I think they deserve all the credit in the world for just showing up and being at the bedside of their child and asking the hard questions and being there and taking care of them.
Yeah. For them, not showing up it's not even on the radar. It's an unthinkable thing. Yeah. And yet it does happen. Amazing. Do you ever wish you'd chosen a different specialty?
Never. Not in medicine. No, I think this is the best specialty in the world.
I love that, because I would say hospice nursing is the best in my view. I'm not a pediatric nurse. That's never been my thing, and I would never want to do pediatric palliative care or pediatric hospice. Is not my thing. But I have such admiration for those who can. So if you had not been a physician, if you had not been a pediatrician or a hospitalist, what career path do you think you would have chosen?
So there's a couple. I wanted to be an advertiser, which has been kind of a funny full circle moment now as someone that thinks a lot about messaging and branding of palliative care, that I feel like I am kind of doing advertising a little bit in a way that's been really fun and exciting to think about. I also, in college, when I was kind of figuring stuff out and started a biology major, got really interested in algae and actually went and lived at a biological field station in the wilderness of northern Michigan and just did science all day and totally loved it and thought I was going to do that. And actually after college worked in a science museum, we're in the algae department, and realized that I missed the people. I liked the 2 months of the year of living in a field station doing science and being with people, and less like the 10 months of writing papers and looking in microscopes and doing kind of the other more academic work of it. And so realized pretty quickly it wasn't the life for me, but for a little while I thought that was going to be it.
Interesting. From algae to taking care of sick kids.
Mm-hmm.
That's a big jump. Okay, so we've acknowledged, we talk about it, right? Ad nauseum, the healthcare system in the United States is broken. One of the reasons we have the podcast, one of the reasons you do medical education and talk about pediatric palliative care is because people who are educated and informed get better care. They're better
Absolutely.
advocates. Yeah, it's absolutely true. but there are still things we want to change, even while we're doing the education. Tell me 3 things you would love to change or see change about healthcare in the U.S.
Yeah, so I think a big part of it is exactly what you said, that people should have control of their own healthcare. And I think whether it's like reading their notes and learning about things, I think that I wish that people had easier access to reliable resources, because I think that that's a huge pitfall, is that so much of what's out there is misinformation or trash or harmful or sort of charlatanry to make a profit off of people's illness.
Yes.
And I wish that I think one of the big roadblocks of people being able to really own their healthcare is that it's hard to get reliable information, and it's not as easily and readily available as bad information. I think the second is sort of learning how to talk about this stuff, that I don't think healthcare workers know how to talk about palliative care and know how to talk about hard things and know how to talk about end of life. And I'll give a shout out to my friend Matt Tyler, who has a YouTube channel, How to Train Your Doctor, that I think training your doctor is important. If your doctor doesn't know how to talk about this stuff, they need to. And I think having pressure from the general public to do that is huge. And then the third is helping train those doctors to do that. Like, I think it's on us as a system that, I heard said once that we only a fraction of the population will ever have a child from their own body. Yet we spend weeks in medical training doing OB and learning all the ins and outs of that. But something that every single person's going to do at some point, come to the end of their life, we spend essentially no time talking and teaching about. And so for me, that's become sort of an area of my education and advocacy work, is working to move that education upstream. And there's a lot of people out there having these conversations with the general public to empower them, which I think is great and important. But I always worry that last roadblock of, no matter how empowered a person is, if they go to their doctor and say, I've heard great things about palliative care, I'd like to meet the palliative care team, all the doctor has to do is say, oh, no, you don't need it, you're not there yet. And it's over.
Yeah.
And so I think moving the education upstream, and then also really naming and creating it as a standard of care. And I think those two go hand in hand. I think having the education so people know how to provide, whether it's subspecialty or primary level palliative care, is crucially important. And it's a standard of care. It's the right thing to do. We're no longer having to sort of ask permission to sit at the table, and should no longer ask permission to sit at the table. And I think moving palliative care from, we're no longer this grassroots upstart field. We've been around. We have people doing it. We have data that supports the work we're doing, and it's robust. We deserve a seat at the table, and we should be demanding it. And I think the combination of kind of training and upskilling, as well as treating palliative care like the standard of care that it is kind of the next step in my mind.
Yeah. Good quality care should not be the exception.
Absolutely.
Yeah. And I'm really struck by what you were saying about, getting your doctor on board, teaching him. I love Matt Tyler. He's been on the show. And the thing about him is, when he's talking about how to train your doctor, he is a doctor.
Mm-hmm.
Yeah. So it's not like he's somebody from the outside protesting against the poor quality of physician care in the U.S., right? He is one of the docs, and he's just telling you how to work the system better.
Absolutely.
But I think we make caregivers work too hard to get good care.
I totally agree.
It shouldn't be that hard.
Yeah. And I do think when we're saying we, I think it's important too that we're clear about who the we is. Like, I think most healthcare workers come to work every day wanting to do a good job and wanting to take care of people and wanting to provide the best care. And I think a lot of the barriers are from these outside forces, whether it's insurance companies or bloated administrations, or, all of these things that don't actually have the primary goal of getting people better health care, that have a profit motive or an ideological motive or something else. That I think, even the phrase good insurance always feels like nails on a chalkboard to me, that like, there's no such thing as good insurance. There's insurances that create more or less barriers to people's fundamental human right of healthcare.
Right. It's complex. It's messy. So, Jared, you are doing some fantastic education in the community. You have some resources available on your website. You've got videos, you're writing and speaking. How can listeners connect with you and the work that you're doing?
Yeah, so they can find me at my website. It's jaredrubensteinmd.com. And then also my social media handle on Instagram, Blue Sky, Threads, and YouTube, where all my videos are, is at Dr. J. Rubenstein. And I love having people go there and putting comments and engaging with folks. I can talk about this stuff all day, obviously. So I think it's important, and I would love to engage and have these conversations.
Well, I will have links to all your socials and your website in the show notes. And I think we're all very grateful that you're open to the comments and engaging. Education is so important these days. If you want to get good care, you've got to educate yourself. So thank you for the work that you're doing. And thanks for talking with me on the show today.
Yeah, thank you very much. And thanks so much for having me. It's been wonderful to catch up with you and have this conversation.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.